So in metastatic bladder cancer, we have very palliative situation. Best and gold standard is a treatment with platinum and combination with gemcitabine. Best use cisplatin. Second best is carboplatin. So the question always has been what to do after 4 or 6 cycles of platinum-based chemotherapy. In the recent years, we expected and have seen a lot of progressive disease, sometimes half a year later. And there was a late-breaking abstract number 1, presented by Tom Powles of the UK, which nicely picked up this unmet need of maintenance therapy in metastatic bladder cancer. And I think this is really a game-changing trial. The trial recruited 700 patients with metastatic urothelial carcinoma in a 1-to-1 randomization. One arm, the control arm, was best supportive care and waiting until progressive disease. The test and control, the experimental arm, was a combination of avelumab every 2 weeks and best supportive care in patients who underwent 4 to 6 cycles of platinum-based chemotherapy. It was an all-comer trial, so regardless of cisplatin or carboplatin, the maintenance treatment or best supportive care was given. This maintenance resulted in a huge delta of more than 6 months. It was 21 months for avelumab best supportive care combination compared to 14 months for the just only best supportive care arm. So really, this is a remarkable difference and clinically meaningful. And I think this sets a new standard in the treatment of patients with metastatic urothelial carcinoma. In the future, we will have to discuss biomarkers since best responses were seen in PDL and PD-1 positive. Aside, we have to discuss the different risk criteria like visceral disease versus bone disease versus lymph node disease. Here, visceral disease has had the least profit. And also we might discuss in the future how much maintenance is needed, how many cycles the patient has to undergo. Is it just 6, or as in the trial, continues until progressing? So these are some unanswered questions, but taken together, I think some here an unmet need, an unmet question is solved with the JAVELIN Bladder 100 trial, excellently presented by Tom Powles. The main take-home message for me personal of the KEYNOTE 426 phase 3 trial, the combination of axitinib and pembrolizumab in metastatic clear cell renal cell carcinoma, was that now after more than 23 or at least 23 months of follow-up time, the initially reported response rates were still durable. So still for the all-comer population, statistical significant overall survival benefit for the combination axi-pembro compared to the control arm with sunitinib. For me personally, and also remarkably, the increase of the complete remission, the CR rate, is now 8.8%. So here we have a good option for our patients with metastatic clear cell renal cell carcinoma in the good, intermediate, and poor prognosis setting. Another guideline endorsed and supported treatment will be IPI or is IPI-NIVO, but this for the intermediate and poor prognosis population, which has been shown in recent trials compared to the control arm sunitinib. So we have a combination therapy for clear cell renal cell carcinoma. I think there is no real space for monotherapy anymore. I personally would not change patients that are stable on TKI monotherapy. So let's say a patient that is good on sunitinib or pazopanib since a couple of years, I would just leave it on and don't change, never change this winning situation. However, when you have a newly diagnosed patient with a metastatic clear cell renal cell carcinoma, I think in 2020 we should give those patients combination therapy. So this was a new renal cell carcinoma and one of the highlights from this virtual ASCO 2020. Thanks a lot.